Welcome to Hematology Case Scenarios, Part 6. In this module, we'll be dealing with cases pertaining to tests for hemostasis, anti-clotting mechanisms, and cell-based concept of coagulation. Case 1. Activated partial thromboplastin time, also known as APTT, was employed as a hemostatic test to diagnose a case of hemorrhagic disorder in a young individual. The lab used a reagent that is a mixture of calcium, caveolin, which acts as a contact activator, and cephalin, source of phospholipid. Citrated plasma clots after the addition of the reagent. The standardized time in seconds is used as a reference to evaluate the intrinsic pathway. Which of the following factors gets activated by the contact of the blood with the exposed collagen in the intrinsic pathway of coagulation in vivo? That's in the body. So here is a situation where a test is done. One of the tests, hemostatic test, was done. That's called APTT, which uses a mixture of calcium, caveolin, cephalin as a reagent. When plasma is added to this agent, the plasma gets clotted immediately within a few seconds, and it mimics the intrinsic pathway of coagulation because of the contact activation. Similar situation occurs in the body when blood comes in contact with the exposed collagen or damaged endothelium. The question is, which factor gets activated by this? Factor 2, factor 7, factor 10, and factor 12. Look at the option one by one. Factor 2, prothrombin, comes late in the coagulation pathway. Factor 7 gets activated by the extrinsic pathway by the tissue factor activation. Factor 10 begins with the common pathway. Factor 12 is the contact factor, so-called a contact factor, gets activated by the collagen. So in the classical Macfarlane's intrinsic pathway, factor 12 gets activated by the contact. Explanation follows. Case 2. A 52-year-old woman suffered a pulmonary embolism a month back on account of deep vein thrombosis that was undetected. Now she is in the hospital for the purpose of monitoring her oral anticoagulant therapy. The test she underwent for the purpose is within normal limits when compared to the reference value. Which of the following tests is used to monitor the therapy of this patient? So here is a case where a person has deep vein thrombosis and she is on oral anticoagulant therapy. So when we use an oral anticoagulant therapy, there is a danger of bleeding because some of the factors are inhibited. Excessive inhibition may cause a bleeding. So we have to keep monitoring using a test, hemostatic test. Question is, which is that test for monitoring? Is it prothrombin time? Is it bleeding time? Is it clotting time? Or activated partial thromboplastin time? If you look at the therapy, oral anticoagulant therapy, dicumarol or warfarin, these drugs, anticoagulants, oral anticoagulant drugs, inhibit vitamin K. So the vitamin K dependent factors are inhibited, and most of these come in the extrinsic pathway. And the test for this extrinsic pathway is the prothrombin time. So answer is the prothrombin time is a test to monitor oral anticoagulant therapy. Bleeding time, clotting times are not specific. Bleeding time is more for platelet, clotting time, intrinsic pathway or extrinsic pathway, activated partial thromboplastin for mainly for intrinsic non-common pathway. Case 3. A similar situation as the previous one. A 70-year-old woman with atrial fibrillation has been taking warfarin for the last 7 years. Her monthly prothrombin time, as expressed as INR, has been maintained consistently within the normal range. 2 days back, the PT was significantly higher than the normal, and she had noticed that her gums bled after she brushed her teeth. Inhibition of which of the following factors has caused the bleeding episode in this case? The situation here is the oral anticoagulant therapy to prevent undue thrombosis within the atria for fibrillation, and excessive inhibition of these factors on which the warfarin acts, that's the vitamin K dependent factors, causes bleeding for minor injuries such as brushing the teeth. So there is no immediate clotting because of the inhibition of factor. That's what happened here. And which are those factors which are inhibited? So we have to select the vitamin K dependent factors, and they are the factor 2, 7, 9 and 10. D is the answer. This is the correct option. The group is 2, 7, 9, 10. The explanation for this will follow in the next slide. Let's quickly go through the relationship between the vitamin K dependent factor 2, 7, 9, 10, the drug that is the oral anticoagulant warfarin, and the prothrombin time. Then illustration. Warfarin inhibits 2, 7, 9, 10. Vitamin K inhibition. These factors are inhibited, so there is bleeding, unnecessary clotting is prevented. Thrombus formation is prevented. This is the action of warfarin. Now, prothrombin time assesses because of the way the test is conducted, adding tissue factors, excess calcium. The extrinsic pathway is mainly triggered. So PT mimics the extrinsic pathway. Factor 7 is activated, factor 10, 9 and prothrombin, of course, in the common pathway it's affected. They're all inhibited. So PT assesses these. Therefore, PT is used as a guide for warfarin therapy. PT should be within the normal limit. If it is excessively inhibited, there is a chance of bleeding. This is what has happened. Case 4. A pregnant woman develops a thrombus in one of the deep veins of her leg, called deep vein thrombosis. Her mother reportedly has a history of thrombophlebitis. The woman has a brother who has similar episodes of DVT during immobilization period following fracture of tibia and fibula. Her blood counts are within normal limits. Results of hemostatic tests are awaited. Which of the following factors has caused the development of thrombus in this patient? So the situation is a family history of thrombosis, especially by immobilization. The immobilization of the limbs is one of the most important factors for development of abnormal clot, which is called thrombosis within the blood vessel, intravascular thrombosis, which occurs mainly in the deep veins, deeply situated veins in the legs, DVT. And there will be some inflammation of the vein, thrombophlebitis. So question is, which is a factor, in the sense, what is a cause of the development of thrombus? Is it the activation of thrombin thrombomodulin complex in the endothelium surface? Is it endothelial prostacyclin secretion? Is it formation of tissue factor pathway inhibitor? or is it the sluggish blood flow due to immobilization? You can easily pick the last one, D, because this is the most important cause, immobilization and sluggish flow. When the blood flow becomes sluggish in any part of the body, mainly in the limbs, the clotting factors get accumulated even if there is a minor injury to the endothelium, and the blood flow does not wash off this factor. They get accumulated and activated, and there is a slow development thrombosis. So there should be a continuous flow should be normal. So there should be a movement of the limbs even during immobilization. This is the most important cause of thrombosis. All the other A, B, C are actually factors that inhibit the intravascular coagulation within the body. Activation of thrombin complex inhibits clotting factors. Endothelial prostacyclin secretion inhibits the platelet aggregation, is counter to the a factor which stimulates aggregation. Prostacyclin is opposite of thromboxane A2, both have opposing actions. So B is not, A is not. C also is a tissue factor inhibitor which inhibits the extrinsic pathway. So they are all factors. A, B, C prevent intravascular coagulation, where D precipitates intravascular coagulation. The factors which keep the blood in the fluid state are explained in the subsequent slide. Now let's go to the case 5. A 35-year-old woman noticed multiple pinpoint red spots and bruises on her arms and legs. The hematologist confirmed them as purpuric spots and ordered a complete blood count. Prothrombin time, APTT, platelet count 35,000 per cubic millimeter. Other blood parameters and coagulation tests were within normal limits. Bone marrow revealed 10 to 12 megakaryocytes per field. Which of the following is the cause of the hemorrhagic spots in this woman? So this is a classical case of purpura due to thrombocytopenia. Platelet count is far below normal. Every other test is normal. The question is, what is the cause? So is it defect in the activation of factor 7 by the tissue phospholipid? Non-availability of platelet factor 3, that is platelet phospholipid, for intrinsic pathway? Is it inadequate closure of capillary bricks by the platelet plugs? Inefficient fibrin stabilization by factor 13 deficiency. So there is a bleeding. We have to say why bleeding under the skin, hemorrhagic spots. Accessory is the person is bleeding, minute bleeding. So they must be due to the abnormal or defective platelet plug formation, which are usually closed. They close the small rents or holes in the endothelium, which are caused due to the blood flow, stress. Minute holes or rents are created in the blood vessels. They're all promptly closed with the platelet plugs. So when the platelets are less in number or abnormal in function, thrombocytopenia and thrombocythemia, there is purpura. This is a case of purpura. So this C is the answer. Inadequate closure of capillary breaks by the platelet plugs. Defect in the activation of factor 7 Tissue factor is not unlikely because the prothrombin time are all normal. Coagulation tests were normal, APTT were normal, clotting time, everything is normal. So B is also unlikely. Platelet factor 3 for intrinsic pathway is unlikely because even though the platelet count is less, and deficient platelet factor 3 may not cause because the tissue factor replaces this. Platelet factor or phospholipid sometimes is known as the incomplete thromboplastin, partial thromboplastin, whereas the tissue factor is the complete thromboplastin that will replace, tissue factor will replace. They're all normal. Fibrin stabilization factor 13 deficiency, there is no indication of factor 13 deficiency. So C is the correct answer. Explanation: platelet plugs close minute ruptures in small blood vessels occurring many times a day. Thrombocytopenia results in defective sealing of cutaneous capillary ruptures and causes subcutaneous bleeding. Case 6. A 50-year-old woman complains of high fever, severe body ache, extreme fatigue and gingival bleeding since 5 days. She reports that she had one episode of epistaxis, that is nosebleed. On examination, cutaneous bruising was observed over her extremities. Hemostatic test results reveal normal prothrombin time, normal APTT. Platelet count again was low, 52,000 per cubic millimeter. Which of the following accounts for the normal APTT and PT in spite of bleeding tendency in this individual? There is a bleeding, but APTT, PT are normal. What is that? Why is that? There are so many options. We have to pick the right option. Normal intrinsic pathway. Is it normal extrinsic pathway? Normal primary hemostatic plug formation, normal clot retraction, normal stabilization of fibrin clot. So, normalcy in few of the normal things must have caused this. The normal PTT, PT. It's slightly confusing, maybe, the question. You have to say which of these will account for the normal APTT and PT. So, when there is normal APTT, we know that intrinsic pathway, common pathway is normal. When there is normal PT, extrinsic pathway is normal. So 1 and 2 we have to exclude. Normal primary hemostatic plug formation. This is an extension of the previous question. Bleeding due to thrombocytopenia, but the cause is the fever, body, that is the dengue fever. This is most probably the dengue fever for which there is thrombocytopenia. Bleeding tendency is very common. The history suggests that. Of course, the investigation are not given. Probably you have to say the dengue fever. So the normal primary hemostatic plug formation must be affected. Clot retraction may be affected because of decreased platelet count. Stabilization of fibrin clot must be normal because there is no indication of factor 13 deficiency. So we have to pick up 1, 2 and 5. So C is the correct answer. Talking about the partial thromboplastin, which is a platelet phospholipid, and the complete thromboplastin, that is tissue factor. When tissue factor is involved, the factors which are involved are factor 7. Tissue factors and factor 7 complex precipitates or initiates the extrinsic pathway. Factor 7 gets activated to 7A, then this complex factor 7 tissue factor complex activates factor 10, it also activates 9, then 10A along with factor 5 converts prothrombin into thrombin and fibrinogen to fibrin. So this is the extrinsic pathway, this block. This is the intrinsic pathway. Here the platelet phospholipid is important because all the factors get activated on the platelet surface. The initiating factor is factor 12, contact factor we have seen. Then factor 11, then factor 10, 9, then factor 8. This is the classical intrinsic pathway. So factor 8 along with activated factor 9 converts 10 to 10A. So 10 is common for both After that, it is a common pathway. Common pathway involves the factors 5 and factor 2. So these three factors common to both intrinsic as well as extrinsic pathway. This is just illustration of how two pathways lead to common pathway, and how two phospholipids, one from platelet, one from the tissues, damaged tissue, take part in this. This is the classical. Now, slightly there is a change we will discuss later. The concept of clotting, intrinsic pathway is not fully explained in that. We will see it little later. Case 7. The following investigations are from a 25-year-old patient with a family history of hemorrhagic disorder. This patient has hemarthrosis left knee. He also complains of excessive bleeding from trivial injuries. Patient has advised administration of freeze-dried concentrate of factors 8. Which of the following is the function of factor 8? It's anti-hemophilic factor. The history suggests hemophilia, classical hemophilia A, because these are the classical symptoms. The patient usually complains with bleeding from trivial injuries and the knee getting swollen up and filled with blood. That is called hemarthrosis. This is a classical presentation of hemophilia, whereas platelet disorders, they present with mucosal bleeding, epistaxis, gingival bleeding, or cutaneous bleeding. So this is a classical case of hemophilia. A person is advised the factor replacement of factor 8. Now, function of factor 12 is asked. Factor 8 is asked. Is it needed for contact activation? Activates factors 10. Does it activate von Willebrand factor? Is it forms a complex with thromboplastin? We have seen already this. If you remember the intrinsic pathway, factor 8 converts activated factor 8 activated by the intrinsic pathway activates factor 10, converts 10 to 10A. So this is the answer. It's not needed for contact activation. Factor 11 and 12 activates von Willebrand factor. Of course, von Willebrand factor is the other way. Von Willebrand factor is needed for the full activation of factor 8. It maintains the von Willebrand factor maintains the plasma levels of factor 8. So factor 8 does not activate. It does not form a complex with thromboplastin. So B is the answer. Explanation to case 7. Let's slightly digress from the case to a little more comprehensive discussion of the clotting and look from a different view. That is, the cell-based concept of coagulation is explained like this, which explains the importance of factor 8 in more detail, or factor 8 becomes a hero here. Factor 8 in the classical intrinsic pathway is only converting 10 to 10A. Let us see what is that role here. Factor 8 is activated by a small amount of thrombin, which is formed by the by the tissue factor 7 activation. This is how it is initiated. Factor 7, this is called as initiation. We'll see that. This mark. This is first stage of cell-based concept, initiation, 7 TPL. So this will activate first the factor 8. Next, the thrombin also activates factor 11, factor 5 and platelets. Activated platelets bind factor 5, 8A, 9A and 11A. So 11 is activated by the thrombin, 8 is activated by the thrombin, 5 is activated by the thrombin The tissue factor 7 complex activates both 10 and 9. So they're all now activated. These factors are activated. This the amplification process. We'll see that later. On the platelet surface now, all these activated factor 9A and 8A plus the calcium which is available converts 10 to 10A. 10A with 5 activated factor 5 and calcium which forms what is known as prothrombinase, which break the prothrombin into thrombin. The proteolytic action of this group 10A, 5A, calcium converts large amount of thrombin into thrombin. Small amount of thrombin has been already formed. This will trigger, and now the propagation occurs. This the resulting thrombin burst then sufficient to enough to convert fibrinogen to fibrin. The initial thrombin activates the factor. The later burst converts fibrinogen to fibrin. Large amount of thrombin also activates factor 13 for stabilization of the clot. So you need larger amount of thrombin for stabilization. So this is how the cell-based theory or concept is explained. It explains the clotting on the surface of cells, first on the damaged endothelium or smooth muscles, initiation, then on the platelet surface. So cells are made given more important and the sequence is slightly changed. They are called as initiation by the so-called extrinsic pathways, 7 tissue phospholipid complex activating these factors, then amplification, this 2 steps amplification, further activation of factor 5, platelet activation, factor 11, then the propagation occurs. So this is these steps are propagation, amplification, initiation. So initiation, amplification, propagation. This is the cell-based concept of coagulation. Case 8. A 17-year-old boy gives history of repeated swollen painful knee that occurs due to minor trauma during football matches. He also had a prolonged bleeding recently following a tooth extraction by a paramedical staff. Platelet count was normal, bleeding time was normal. Further 2 lab tests lead to a tentative diagnosis hemophilia A. The 2 lab tests that confirm the diagnosis are very easy question. It's a classical case of again hemophilia, hemarthrosis. Is it prothrombin and APTT? No, prothrombin time is for extrinsic pathway. Here mainly the intrinsic pathways involved. Factor 8. Activated partial thromboplastin and factor 8 assay. This must be the answer. Prothrombin time and factor 7 assay. Factor 7 does not come here because hemophilia affects factor 8, so it must be factor 8. Estimation of plasma 1 millibrand factor is a partial answer, but serum bilirubin level need not be tested because there is no indication of hepatic failure. Only factor 8 is involved. So it's not a liver failure of liver to synthesize clotting factor. Other factors should also be affected. Bilirubin is not a correct answer. Estimation of plasma is okay. So, but the most correct answer is the activated partial thromboplastin time. APTT is assesses intrinsic pathway where factor 8 is involved mainly in the classical coagulation pathway, and factor 8 assay